My name's Kelly, and I'm going to be your moderator here today. We are pleased to be presenting you a session called Don't Let Oncology Currents Sink Your Ship, Life-Saving Tips for the WOC Nurse. We're honored to introduce here Melissa Hiscock. Has worked over 18 years at Roswell Park Comprehensive Center in Buffalo, New York, 15 of these as a certified wound, ostomy, and continence nurse. Melissa currently focuses on wounds, ostomy, continence-related nursing issues, as well as nursing research and evidence-based practice and managing the WOC nursing department at the center. Melissa is completing her PhD at the University of Buffalo with a research focus on pressure injuries in the patient with cancer. Everybody, welcome Melissa.
So bear with me. Can you hear me okay? Can I talk about it? No? Okay. We're going to carry on. I'll try not to make all those weird noises. Here are our objectives for this talk today. Basically, I want you to understand the impact of cancer on skin integrity and then on wound healing. We're going to talk about precautions we need to take for different patients with cancer and their treatment options. And then to look at and understand common skin manifestations. Throughout this talk, the slides are going to have these little like life ring, right? With little tips for you. These are just little tips that I learned over the years that have helped me care for our cancer population. And Roswell Park is, we're solely a cancer center. We only deal with oncology patients, so that's really been my sole experiences with oncology. I did do some home care and with hospice, but I've been an oncology nurse from the beginning. So let's get started, because I got a lot to talk about. I usually like to start with the basics, whatever I'm doing, but I skipped the basics for skin and wound healing, because I think we all know all about that, I hope. So we're going to talk a little bit about cancer here. So some data. Almost 2 years ago, cancer.gov estimated over 18 million cancer survivors are in the U.S., and this is projected to increase to over 22 million. And a survivor now is someone that has been diagnosed and is living with cancer. And in 2019, there's an estimated over 54 million adults over 65 years. I want to focus on this age piece. Advancing age is one of the main risk factors for cancer. So we are going to have an older population, a population with more comorbidities, and there's going to be more disease, more cancer disease. So we have to be aware of that. And to bring some more data, really like data, we have NCI on the left here, and then our census on the right. So NCI is demonstrating that it's hard for me to see the graph. By 2040, there's going to be 26 million people over the age of 85 surviving with cancer. 85 years old surviving with cancer. And then on the right-hand side, census tells us that by the year, what year? I'm sorry. 2060, excuse me, I'm so sorry. We're going to have over 25 million people aged 85 or older, just to reinforce that age and that increased cancer prevalence. And I want to stress this because it's not only, cancer patients aren't going to be just admitted to cancer centers, but they're going to be admitted everywhere. So we all need to be aware of how to deal with patients with cancer. So when a patient has cancer and wounds are present, practitioners, healthcare providers need to be able to determine what the cause of that wound is, right? And it's not an easy thing. Cancer really throws a wrench into that differential diagnosis. We have to negotiate what it is, what it isn't. What cancer does, the cancer process can result in fatigue, pain, poor sleep hygiene, a lot of insomnia, unexplained weight loss, bleeding, bruising, and then other cutaneous manifestations. And treatments of cancer results in healing, post-op complications, increased risk of infection. We have impaired collagen synthesis related to some treatments, anemias, and then skin toxicities and adverse reactions. So what else, besides the cancer diagnosis, we add a wound into it, and how does that wound impact that patient with cancer? It adds to physical pain and discomfort, hugely impacts their quality of life. We've already have a decrease of quality of life, and this wound just compounds that. There's psychological distress, stigma. Alopecia is one of the most stigmatizing side effects of cancer treatments. Some patients won't go through with cancer treatments if alopecia is one of the side effects, unfortunately. A wound contributes greatly to the financial toxicity that cancer treatments result in. And then wounds also cause a delay in treatment, which then has an impact on cancer progression. If they can't get their treatment, their cancer is going to grow. So what are cancer wounds? I found this diagram, this infograph in a research article, and I found it very interesting. And what it described in this study was that cancer wounds are stuck in the proliferation phase. So versus what we're commonly, familiar with, is the wounds get stuck in the inflammation phase. Yes, that's how chronic wounds become chronic. They're in the inflammation phase. But cancer wounds get stuck in that proliferation phase. That's where they continue to have angiogenesis and the cells continue to grow and replicate. And that leads us to fungating tumors. So with that said, with that increased proliferation, increased angiogenesis, we're constantly growing. We're just stuck there cycling in proliferation. These fungating tumors grow. They're very vascular, it's very fragile, bleeds very easily. The goals for care for fungating tumors should be focused on controlling drainage, controlling odor, and then preventing further trauma and bleeding. When these wounds bleed, it's very difficult to get them to stop bleeding. Basic wound care plans should include, you can cleanse with saline or you can use a hypochlorous cleanser. You can use metronidazole up in the top there with your little lifesaver. I recommend that when you use metronidazole powder, that you put your contact layer down first and then sprinkle the powder on top. The powder, if you were to put the powder on first, it tends to get into all those little nooks and crannies and crevices and creates kind of a mess. So if you put it on top of the contact layer, it keeps things a little bit cleaner. And cover with whatever, I don't want to say grade, but whatever level of absorptive dressing that you need, depending on the wound, depending on the drainage. And keep it simple. Sometimes if you have a heavily draining fungating tumor, you might need to use, maybe it's a brief. You open up a brief and wrap it around them. I'm referring to a breast wound. Or sometimes baby diapers work. Maxi pads are a great absorber, whatever you want to say. They can stick inside their clothes if they want to use those. And another fungating tumor, a little bit trickier to dress, but we still maintain the same goals. For this gentleman, we used a foam, kind of cut it, notch the edges so it would lay a little bit flatter around this tumor. But we did use hypochlorous wound cleanser. And with things like this, you really need to be creative. Wraps, garments, you want to avoid adhesives because the skin around fungating tumors can be just as fragile as the actual tumor itself. One of the things that we've done, we didn't do it for this gentleman, but we've done in the past for like facial wounds or head wounds, is using like a ski mask, just cut the face out and put a ski mask, is it called a balaclava? Yeah, okay, there you go. You guys know what I'm talking about. But that held everything in place, and they can just go buy them and then change them, wash them, whatever. And going back to our first patient there, what I want to focus on here is other things to consider when planning their care. Really ask them what they want. For this young lady, she was planning to go to Disney. This was on her bucket list. Her cancer was progressing so quickly. And they were going to Disney with her young daughter in a couple months. So we had to plan care that was going to be something that would travel, something that she could potentially change in the bathroom at the park. We have to think about sweating. Are we going to be using adhesives if we had to? What can we do for her? what we did do, she was able to kind of keep things in place with different garments and wraps, and able to use, I think she actually used maxi pads because they were easier to put in her bag and just kind of swap out in the bathroom. But she went and it worked. There was another patient that I like to share that it was with hospice. She had this eroding breast tumor, breast cancer, and was called out to her home to see her. And I really wasn't, I had never seen anything like this, and I haven't since. But I took her dressings off, and when I looked at her, you could see it through her chest wall, and you could watch her breathe. And the tumor had eroded right through her rib cage. And I thought, oh my gosh, how is she still like just here talking to me? And she's not in, an enormous amounts of pain. So I covered her back up. I'm like, all right, thinking in my head, what the heck am I gonna do? So I asked her, I said, what do you, not in so many words, I think I said it nicer, but what would you like me to do? What do you want from me? And she said, I wanna go to church. I'm like, all right, let's rethink this. How long's church? And I think she said like 2 hours. And she was cutting it, short for her. Usually church was like an all-day event, and they did dinner, and it was, it was a big thing. She's gonna do 2 hours, and she had some high neck sweaters that she could wear. So we got her all padded up. We used some alginates. She had a contact layer over. We used a brief to absorb drainage, and I'm thinking we used metronidazole powder also. This was a number of years ago. But she was able to go to church. She came home, and then she ended up passing away shortly after that. But just to keep that in mind, to ask your patient, keep in mind to make sure that you're meeting their needs as well as yours. Healing is not always everyone's goal. Moving on to other cancer wounds. Mycosis fungoides is and Sézary are manifestations of cutaneous T cell. And I've seen different presentations of this. They're almost, what I've seen in my practice, almost like little eruptions. But they range from plaques to tumors. Best treatment is with UV therapy. They do use immunotherapy for these, topical steroids, retinoids, all the things. Wound care on our side is basically just kind of, same thing. You're managing drainage, managing odor, decreasing the bioburden of the wound. And you have to remember that for these types of wounds, you're not always gonna solve the problem, right? You might be just managing it, but the cancer treatments, the cancer drugs are gonna be solving the problem. Again, for our little lifesaver tip, sorry, I skipped over that part. Avoid adhesives. I can't stress that enough. The silicone tapes that we have on the market now are nice, but if you can avoid adhesives altogether, it's the best way to go. Now, Sweet syndrome, I don't know if you've ever heard of it, but I've seen it a couple times. It's not only seen with cancer patients, though. It's seen also with drug reactions and inflammatory reactions. It's acute febrile neutrophilic dermatosis. It's a sudden onset, and there's varying presentations, as you can see in that photo. And it typically affects the arms, the face, and the chest. Dermatology consultation is really critical to determine and to rule out other diseases such as like pyoderma. Those kind of look like pyoderma to me. Herpes is another one, and cellulitis. Typically they'll see with that skin biopsy is dense neutrophilic infiltrates in the dermis. Pardon me, I'm really dry. All right, so beyond our cancer wounds, cancer causes, we have impaired skin and wound healing during treatments. So you have acute skin reactions, which can be caused or affected by patient-related factors, and then you have treatment lumped in there, and then you also have chronic conditions and comorbidities. It's like this giant mess, right? All these symptoms. And with those, you have the comorbidities and then your cancer treatment on top of that. It compounds the effects of cancer treatment sometimes. So then you're going to get more pronounced adverse reactions. Chronic skin reactions are generally caused by the treatment itself. You have altered skin and tissue composition, chronic non-healing wounds as a result of decreased perfusion and impaired vascularity, and then peripheral neuropathy. Whew, that's a lot. And then we know this list, I think, chronic conditions contributing to healing. So we're going to lump that in here. We have decreased perfusion with our cardiovascular disease and PVD, lymphedema, throwing a wrench in things, decreased oxygenation with pulmonary diseases. I think this gives us a nice picture of what's going to happen with our aged community. And then we're going to talk about patient-related factors. So we have age, we're getting older, malnutrition, low performance status. We have the ECOG. We use the ECOG and the Karnofsky at our facility to measure performance status, and there's also the Lansky you can use. The site of treatment also affects their outcomes, radiation, smoking, and then if they had a previous sensitivity to a treatment, is going to determine their adverse reactions. This is just an example of a patient where, all these things, all these, lifestyle, their comorbidities, their treatments affects their wound healing. So this gentleman is a smoker, history of alcohol abuse, uncontrolled diabetes. I mean, this probably sounds like a lot of our patients. But then he had radiation to his head and neck for the cancer, and then he had a course of chemotherapy. So we have a lot of dehisced wounds here. The big thing here is, we're dealing with an airway around his trach site, so we have to be really careful about what we're putting there. Is it going to stay in place? We want to make sure we're not using any petrolatum. So what we did was hypochlorous soaks and then a silver hydrofiber, and then we used the trach ties to hold everything in place. It wasn't perfect. We did our best, but he did heal up eventually after a long road. And we used negative pressure on that donor site on his thigh. And now treatment-related factors. So we sorted through all that other stuff. Chemotherapy, before I say all this, because I keep forgetting, as I reviewed all this, I keep forgetting to point out the ONS guidelines. If you aren't a member of ONS and you're taking care of a lot of cancer patients, I would recommend becoming a member of ONS. There's a lot of great resources, and they have forums. You can ask questions. It's really, I can't speak highly enough of ONS. But so chemotherapy affects the cell cycle phases, as you can see in that little diagram. So the G1 phase, S, G2, and M. So all of these skin manifestations are a result of whatever phase that chemotherapy is attacking. I know we really don't have to remember all this, but it gives a little bit of foundation for our knowledge. So hyperpigmentation is a result of damage caused to all cell cycle phases. It's an increase in melanin production. Sun exposure exacerbates hyperpigmentation. We can also see post-inflammatory hyperpigmentation, which I see a lot. The skin is like a gray-purple. Typically see this with alkylating agents like cyclophosphamide. A disruption in the S phase, this is our DNA synthesis phase. This causes rashes. You'll see hand and foot syndrome and hyperpigmentation, of course. And this is from typically seen with antimetabolites like gemcitabine. Then the M phase, again, hand and foot, you'll see nail changes. And this is typically from taxanes, paclitaxel, and docetaxel, and then anthracyclines. Urticaria and acral erythema are associated with hypersensitivity reactions. And then traditional chemotherapies cause sensitivity. There we go. Can't say it. We have to take caution in the sun. There we go. I want to say photosynthesis, but that's not what we want to talk about. Photosensitivity. There we go. But they really need to be careful in sun. Stay out of the sun. Always use sunscreen. They need to be covered head to toe because that sunburn is like nothing else. And neutropenia. Neutropenia is absolutely critical to be conscious of, and thrombocytopenia. We don't want our patients bleeding out. About 2 weeks after chemotherapy is administered, there's a period of nadir. This is where their counts just bottom out, right? They don't have, they lack immunity. They can't produce an inflammatory response, so you might not see those typical signs and symptoms of an infection. So that's why it's super critical for us as wound care providers to control that bacterial burden in the wounds, prevent trauma and bleeding. You don't want them to be bleeding. They don't have the tools to clot. And then provide conservative care until those counts recover. You're not going to see your normal signs of healing until those counts recover, and then they'll start to show signs of healing. For this person here, he came in with neutropenic fevers. He's had a bone marrow transplant in the past. Skin inspection revealed these types of lesions in his abdominal folds, in his groin, and the gluteal cleft. So the medical team handled the neutropenia. He was on antibiotics, a bunch of other stuff. And so on our side, we need to manage the wound by controlling bacteria and moisture. So we did use hypochlorous soaks and silver hydrofiber. And then once these were epithelialized, we could use our wicking textiles to manage those areas. This is another interesting case. So this is over a course of a month. And you might look at this and think, like I did when I walked into the room, like, ooh, I want to get like a melon baller in there and scoop that out. But we can't. So this is a 47-year-old male with AML. I get a transplant in 2019, failed multiple treatments. He was admitted with pneumonia on antibiotics. This wound that he had was over a year old from a tree branch scrape. He had a history of smoking and drug abuse. On multiple courses of antibiotics and antifungals. I don't think there was anything that he did not take, but the key was he's neutropenic and thrombocytopenic. So we had the surgeons come in, and he's like, no, we can't open that up anymore. We have to just kind of watch and wait, because he doesn't have the tools to fight any infection. The bone is probably going to be exposed underneath there, so he's at risk for osteo. And that wound is going to be very difficult to heal. So we have to follow conservative management. So we protected the peri-wound with barrier cream, and we use quarter-strength hypochlorite to try to clean that up pretty fast. Did an ACE wrap to reduce the edema, and then we did that daily. Moving on to another condition that we see frequently, and I've seen some pretty bad cases of this, acral erythema, or hand and foot. That's what we usually know it as. Painful erythema, with or without bulli, preceded by diaesthesia or altered sensation. Usually about 2 weeks post-treatment, and it lasts about 2 weeks, except the case that I saw, it lasted. I think he was immobile for a good month, maybe 2 months. The bulli just encompassed his feet and his hands. We had to almost treat him like a burn patient. So he was bedbound for quite some time. The mechanism is really unknown. Some literature says it is related to the eccrine glands. The chemotherapy concentrates in the sweat glands. So we see acral erythema, hand and foot, and then in intertriginous areas also. So that would explain kind of the sweat gland association. And then most frequently seen in those meds there. So really, for a life-saving tip, it's basic wound care. We want to control the drainage, control inflammation, and protect from trauma. Keep it simple. Erythema multiforme is kind of like a lead-in to SJS and TENS, so Steven Johnson's and toxic epidermal necrolysis. But high-dose combination therapies create the highest risk, and it's kind of a compounding effect. And there's some common drugs listed there. And all hands on deck, really, when you see SJS and TENS. And if you've seen it, you know this. And it's absolutely critical to be collaborating with the whole medical team. Rashes, when you have patients that are on high-risk meds for these conditions and you see a rash, you need to be like, whoo, we got to make sure we're covering all our bases here to make sure it does not progress to SJS or TENS. So wave your little flag for help. Your VEGF inhibitors are the major contributors, so that's vascular endothelial growth factor. That makes sense, right? Examples of these are NIBs and MABs. The big one for a MAB is bevacizumab, and we'll talk about that in a couple slides. Acneiform rashes are very common, and it's I can't think of like the right word I want to say. It's not harmful, but it's debilitating for the patients. They don't want to go out in public. They're embarrassed. They have this really bad acne. It occurs on the face and the upper body. And it's the EGFRIs. And treatment can include oral tetracycline inhibitors and topical steroids. One treatment plan that I did find in a research study was using ivermectin and doxycycline and betamethasone, and they had really good effects with that. But looping in the dermatologist is really important here, and then ruling out infection. Now, this isn't a big, gross, ugly wound, but painful fissures are very common, and they usually happen a month to 2 months after therapy. And again, those EGFRIs are our culprits. Different treatments are listed there, and really, it's key to keep them clean, keep these fissures clean and moisturized. Managing inflammation can also help with the pain. Sometimes silver nitrate can be used on some deep fissures to freshen up those edges and get them to start to heal again. And radiation, the gift that keeps on giving. So radiation targets rapidly dividing cells. And I want you to remember, go back to, our WOC school, and we learned about epidermal regeneration, and it takes 21 days for that epidermis to regenerate. That takes 21 days for that basal layer to migrate up, right? So that's sort of the foundation of how radiation affects the skin. You're gonna see the effect of radiation in about 3 to 4 weeks, and that's when the basal layer has gotten to the top. So acute toxicities are a common adverse effect, ranges from like a sunburn looking to, you can have blistering, you can have necrosis. Intertriginous areas are the highest risk because the skin is a little bit thinner. There's moisture, there's friction. So we really need to, be on top of those areas. Here's some pictures of different radiation injuries. You can see the dry desquamation at the top, and then we have some moist desquamation in that larger picture. There are permanent changes that can happen. We can have fibrosis, ulceration, necrosis. Skin folds, again, are at high risk. Really, I can't say it enough about collaboration, but when we get called down to radiation medicine, it means there's a really bad problem. They usually handle everything themselves. So this takes a lot of collaboration with the radiation team to kind of coordinate care. You have to time care because they get radiation treatments every day. So you're going to have a daily treatment. You can't use any, petrolatum or anything that's going to stick to the skin, make it greasy. You really want to avoid adhesives because you're taking that dressing off every day. And that skin gets more and more fragile as time goes on. We've had really good luck with honey products because just some warm water gets that off. Foams are helpful. When you're thinking about daily dressing changes, really consider the cost of what you're using. Try to keep it really simple because those costs can add up, especially if they're paying for these treatments. Gentle care is critical. Pain management. Sometimes topical steroids are helpful for that inflammation. And really, I can't say enough how important it is that you are able to get that skin clean and dry before they go for their radiation. Anything that's on the skin can either block the treatment or it can enhance it. So be very careful. And then radiation recall. So this happens down the road. It can happen years down the road. They get a medication. It's usually, there's a list there, anthracyclines, alkylating agents, antimetabolates, taxanes, can trigger this radiation recall, and they get the same sort of skin manifestation that they had initially. There isn't a lot of research behind it. It's poorly understood. But the key is you got to provide, basic wound care. You don't have to deal with the daily treatment option. You can use whatever you want to for your advanced wound care. And this recall effect can range from erythema to, they can have necrosis, they can have everything all over again. And surgical complications. There's surgical complications everywhere. So this particular wound, this is a dehiscectomy incision. We don't usually see them, but this patient was diabetic, he was obese, he had had chemo and radiation to this area. He dehisced and developed a fistula as well. So that tube is actually going into the fistula site. And we used negative pressure on this site. It eventually healed, but he obviously had infection. He was septic, and multiple trips back and forth to the ICU. But the key here is that neoadjuvant therapies, meaning, chemo and radiation before they have surgery, that increases the risk for surgical complications. Chemotherapy and radiation affect those rapidly dividing cells. So mucous membranes, intestines, they're going to be very friable, very at risk for dehiscence. So, and yes, readmissions because of all of these things. And because they are so sick, pressure injury is a risk also. Pressure injury is also a high risk outcome, or a risk of, let me rewind. Pressure injury, obviously, is a risk from some of our long cases. We see the most pressure injuries or related pressure injuries from our head and neck cases, which are, they're high risk going in, but those cases are 14, 16 hours, and they're in these weird positions. So yeah. And chemotherapy, going back to chemo and wound healing, chemo brings with it multiple side effects that impact quality of life, okay? So skin manifestations range from rash, dryness, kind of easy things, to hyperpigmentation, to blistering, to desquamation. It runs the gamut. And most chemotherapy functions by inhibiting cell metabolism, division, and angiogenesis. We already talked about that. And it also interferes with the stages of cell division. But in terms of wound healing, it interferes with inflammatory processes, like extracellular matrix production, immune function, thereby increasing your patient's risk for infection. One of our, I wrote prize fighter in here, bevacizumab is like, this is the doozy. It's an angiogenesis inhibitor by acting on that VEGF pathway. It really, it causes dehiscence, bleeding, infection. Timing of treatment and surgery is absolutely critical when we're dealing with bevacizumab. I know you don't really have an impact on when surgery is, but it's good to be aware of, what can happen if this timeline is not followed. They suggest that surgery be 6 to 8 weeks after bevacizumab treatment. Or on the other end, if they have surgery, they should not get bevacizumab until a month after surgery. Extravasation, it's not only seen in cancer population, it's seen with any vesicant given, right? But it's an infiltration of a vesicant administered mainly by peripheral IV, but you can see extravasations through any route of delivery. It could be through a port, through a central line. It can still happen. The key to extravasation is prevention. We have to know what we're delivering to the patient. This involves a lot of education to the bedside staff. But we do, we are involved when it happens via, developing a wound care plan and then surgical consultation. Again, lifesaver tip, early identification and prevention is key. If you're called to see an extravasation site, I would rope in plastics ASAP, and don't be afraid to call a hand specialist because they really need, intricate debridement to be able to maintain dexterity. We have pretty extensive algorithms at our facility. Our wound care team is actually on the extravasation council because we are pulled in frequently to assess sites. But this is just an example of some of our algorithms. Another sort of cutaneous manifestation that we see is secondary lymphedema. This is frequently underdiagnosed and misdiagnosed. It's not curable. We've damaged lymph nodes through surgery, radiation. Sometimes it's the tumors pressing on that lymph node, so lymphedema develops. It's really critical to treat the lymphedema. We have lymphedema therapists at our hospital, and they do wraps. And this is, it's a lifelong thing that they have to deal with. And then we help with, maintaining skin integrity and providing those wound care recommendations. And that can be tricky with timing. You need to have, we've all done wraps before, you need to have the right absorptive dressing. We need to be controlling bacterial burden. And then also keep in mind those costs of treatments. And then probably what you've all been waiting for is graft versus host. So graft versus host of the skin is, I'm not an expert in GVH by no means. I'm not an expert in transplant. I was a surgical nurse before I became a wound nurse. So leukemia it's like I don't know, not unknown to me, but I'd like to know more, but it's so complex. Anyway, it's associated with allogeneic hematopoietic stem cell transplant. Okay, skin GVH is the most common sign of GVH. It can occur in any other organ, really. For example, the gut, and that causes, horrific diarrhea, and then more skincare issues that we have to deal with. And it can range. You can see the different variations here, but it can range from a rash, which you see on that back in the hand, all the way to bullae and necrosis. But we've gotten better at transplants, so you don't see those extremes anymore so much. Very rare. When I first started my career, I was kind of horrified by GVH of the skin. I was terrified. I didn't want to go there to see those patients, but you have a job to do, because I was kind of like, I don't know what to do. But you learn, and we don't really see that anymore. We see more of chronic GVH, which we'll talk about in a second. So treatment. The medical team is going to handle immunosuppressive therapies, steroid therapy, antibiotics, pain management. The patients are probably going to need serial debridement. There's, a lot of dead tissue that builds up, biofilm, which quickly builds up. They require irrigation and extensive wound cleansing to control that bioburden. We're maintaining moisture balance. The skin on these folks tend to be really dry, and the wounds tend to desiccate, but they also get a lot of edema. So you're going to be managing a lot of exudate sometimes. Compression therapy is sometimes warranted in those lower extremity wounds to manage that edema. But be very cautious with whatever treatment that you're doing, because that skin is so fragile. And they have a lot of neuropathic pain typically. Their skin almost becomes like plastic. It becomes very woody. That's how they describe it. It tears very easily. Because of the long-term steroids that they've been on, their collagen doesn't, it's not effective, and it doesn't produce as it should. Sometimes collagen is helpful to restart those wounds. And silver is also very effective in these folks. One of the things I do want to point out is, in that life-saving tip, is just to be patient. When you're dealing with a GVH wound, sometimes it's just, you do 2 weeks of this. Okay, that's not working. I'm going to do 2 weeks of this. And they're just going back and forth with the medical team, making sure that everything's being managed. We have had good results with hyperbaric with these patients, but it takes a lot of patience. Don't throw your hands up immediately, because you're not going to see changes that you want to see immediately. I have a series of pictures of one young lady here. She's a mantle cell lymphoma patient. She had a transplant. We're seeing GVH of the skin. She's got open areas, patchy erythema. You can see that, some blistering. She has decreased range of motion and weakness. She's got these non-healing lower extremity wounds. She's had them for quite some while by the time she comes in here, with an exacerbation due to sun exposure. I'm not going to say photosensitivity. There we go, photosensitivity. Current care, she's been seeing an outside facility. She lived in kind of a rural area. And current care in the notes was diluted bleach. I kind of like that. And topical creams. I don't know if she was making it herself, but but we all know what that is. So same patient, 3 years later. I want you to see that gray appearance of her skin. That is very common. And it's normal. They get this grayish discoloration. There's a lot of scarring in that woody appearance. The skin loses its elasticity, and you can see her stunted nail growth there. So some of the symptoms of chronic GVH, we have color changes. You saw that. Thinning or thickening of the skin, depending on the site. They get rashes. They get really scaly. They get bumpy. Their skin just changes in all ways it possibly can. They can feel pulling or tightening. The skin becomes sclerotic, so that can interfere with their mobility and range of motion. So it is really absolutely critical for them to keep moving, or else they just, they tighten up. And the wounds heal so very slowly. Some tips for non-pharmacological things: keep them moisturized, gentle stretching. They can work with physical therapy. Gentle massage is helpful. Again, reduce that sun exposure and avoid crossing your legs. You don't want to decrease that blood flow. And this is the same patient. All right, now she's back in the hospital. Her GBH has gotten pretty bad. She got very depressed at home and wasn't really taking care of herself. And she wouldn't let her husband do things for her. So now she's confined to the bed. Her mobility is very limited. She's got multiple pressure injuries now, and then those GBH wounds. For this particular person, what could we do for prevention? It's like throw everything at them. And we did. We really need to reposition these patients. Advanced support surfaces are absolutely necessary. Moisturizing and protecting their skin with dressing, sometimes clothing. If they're able to wear like their normal street clothes, I always recommend it just to protect their limbs. And for her, we did hypochlorous soaks. We used some multi-layered foams, and she was on a boatload of other things. How am I doing on time? I see you 10. Okay, we're getting there. All right, I'll be fast. All right, so we know another patient with chronic GBH. For him, I want to point out his shoes. He said his legs were too edematous to put his sneakers on, so we put these shoes on. So I would recommend we need to loosen these shoes or get him different footwear because he's going to have some wounds underneath those straps. And also his arms. See the discoloration, the multiple scars. This is just a typical presentation. And then another breast cancer patient. We saw some nice changes with this one with a really simple treatment plan. A little background on her. So she's metastatic, bone and liver. She's got new lesions to the lung. She was diagnosed in 20, but had treatment and worsening disease now. And she was a smoker. So our plan, we like these hypochlorous soaks, and it worked really well for her. And then we used absorbent foam and some silicone tape, and we did every 3 days. I was actually pleasantly surprised at the outcome of this. Other options, like we talked about before, metronidazole, petrolatum gauze, any cover dressing, and then secure with clothing wraps. With breast wounds, you can sometimes get them to wear a camisole or a sport bra if it's not too irritating. Whatever you can do. And then normal things that just happen more frequently due to, we've talked about all the things that happen to the skin, all the changes that cancer treatment causes. We see a lot of skin tears, pressure injuries. It's the nature of the beast to see, things to happen at life's end. Fungal rashes. Everybody's on antibiotics, so we're going to have fungal rashes. Diarrhea, malnutrition, tubes and drains leaking. So this patient had this awful site, and he had radiation to that area. You can see the little tattoo. So his skin is at risk, and then he has a leaky tube. This area was super painful, horribly denuded. We used a long-lasting elastomeric polymer cyanoacrylate skin protectant. That's a mouthful. But this is 3 days later. We had a great outcome with this, and it healed right up with a new tube, though, too. And then pressure injuries. I'm not exactly sure why I put Rocky in here, but maybe to give us a boost. I don't know. But pressure injuries. I mean, this is my passion. So there's a lot of research devoted to acute care, critical care, and pressure injury prevalence, but not a ton devoted to pressure injuries in our cancer patients. But what is out there? The prevalence is roughly 13 to 26%. That's a pretty big range, but it's about double that of acute care. I want you to keep in mind metastatic disease and pain are going to contribute to how you prevent pressure injuries in the cancer population. Spinal cord compression is a big thing. You're not going to be able to turn patients like you would normally. Bony mets, you might not be able to turn them because of the bony met. Maybe there's a fracture, or it's pain. They have a lot of pain with those bony mets. And fungating tumors and cutaneous lesions could be on a site that you want to turn them onto or position them. And then we have to deal with avoidable versus unavoidable, which we're not going to get into right now. It's a whole nother lecture, right? I find with prevention that education is absolutely critical for our patients, and even some tough love sometimes, telling them that, you really need to turn, you really need to get out of bed, you got to do this, you can't get, I always say bed sore, I know that's an old term, you can't get a bed sore because you need to finish treatment, right? You got to finish treatment, and this could hold up your treatment. We do a lot of rental surfaces, low air loss, Micro shifts are important, especially when you're dealing with not spinal cord compression, bony mets, and when you're having difficulty with repositioning, use those micro shifts. And lastly, I want to talk about pain a little bit, because I'm running out of time. Pain is a real thing with cancer patients, and it increases with metastatic disease. It could be nociceptive, which is caused by damage to body tissue, or neuropathic. You could have acute pain with your dressing change. You could have normal chronic pain that they manage, but then this chronic pain could be exacerbated with the dressing change. There's also a real thing as anticipatory pain. They see you come in and they're like, and anxiety, pain through the roof. And then bad news and treatments can exacerbate pain. And regarding wound care, dressing removal is the most painful time, and pain is actually what the patient said it is. So listen to them, please. Some pain management during your wound care. Know your patient. Have a discussion. Pain is different for everyone. Avoid verbal anesthesia. I'm sorry doesn't help. Doesn't take away the pain. Explain the procedure. Be realistic. Okay? Nothing is pain-free. So make sure you say that. Being organized is helpful. Reducing the time that you're actually doing the wound care. Allow for timeouts. I like to bring a friend when I'm doing wound care like this to either hold their hand, talk to them, distract them, sing a song terribly, whatever it takes. There is real evidence to support the management of pain and anxiety in wound healing. Some different tips to manage pain. We want to maintain moisture, silicone dressings, protect that peri-wound, reduce the frequency of dressing change if you can. Get them involved. The PEDS lecture earlier, we talked about getting the kid involved in their ostomy care. So same thing with the patient. Give them some control back and manage inflammation and infection. Lidocaine and morphine hydrogel are available. I'm flipping through these pretty fast. And then managing their anxiety is going to help with their pain management. So keeping things low-key, cool, manage your own anxiety, maybe count to 10 before you go in there. But that's going to help with their pain outcome. Real quick, a right hip met patient. So he developed a pressure injury due to the inability to reposition properly at home. So he came in with this. Our treatment, we wanted to avoid adhesives because that skin was so fragile, and we wanted to reduce the time that he was actually over on his side on that painful area. So we used barrier creams. And we pre-medicated, and then we also got a better support surface for him. I'm not going to read all of this. This is a very complex patient, ended up with a stage 4. He had GVH, post-bone marrow transplant, everything that you could possibly throw at somebody, and a very, very long length of stay. So this long length of stay, and this is for any patient, long length of stay increases their insomnia, and with that comes anxiety, with that comes depression, and with that comes pain exacerbation, right? So we have a lot of things to manage in this particular case. Managing anxiety and delirium, insomnia and delirium, controlling the bacterial load. This is where we come in. Pressure management, and then the medical team can manage the meds. Then there's also a thing with hyperalgesia. This is a real patient. She's not a cancer patient, but she had hyperalgesia. It's opioid-induced, and what happens is the pain increases as the drug dosage increases. So it's just an opposite effect. And we have to differentiate between tolerance and sensitivity. So when she was finally admitted, I'm not going to go into the long story with her, but when she was finally admitted, the pain team weaned her off her opioids, and we were able to kind of restart again. And this is her. She went through multiple surgeries, grafts, ostomy placements, reversals. We never really healed this, but she was able to go home and be with her family, and she passed away shortly after that. One of the things that I did want to point out here is anticipatory anxiety and pain. I spent a lot of time with her, and every time I was with her, I hurt her. So she would see me, she'd be walking in the hall with PT, and she would see me and she would start crying just because it was like this trigger, this response. So I started to see her more frequently to kind of, counteract that anticipation. So maybe, a little trick you can use down the road. And then lastly, end of life. So end of life is a real thing with cancer. It's a very mortal disease. So we have to be thinking about, when is it appropriate to turn? When is it not appropriate to turn? It's, it's the patient's time, it's their quality of life and how they want to pass away. So we need to have that at the center of our care plan versus, what our policy says. But always keep those patients' goals a priority. Sometimes it's even requiring family and caregiver education. And don't be afraid to bend the rules. That's it. This is the end. Questions? She's,
Yes. I'm going to run them. It's not another one. Oh, do you have one? Okay. Just need maybe for everyone needs to speak into it because we're recording.
Catch my breath.
Or it will be caught on the.
I have a question about preventing radiation dermatitis. Do you have any recommendations for prevention?
Not really. Our radiation medicine team handles all that, and it's dose specific. It's up to them to prevent dermatitis. They'll send patients home with moisturizers. That's really the only thing they could do is.
It's just like Aquaphor, that's
Yeah.
it? There's no other evidence-based? Okay, just curious.
That's just
yeah.
what's going to happen, with the treatment, and then they monitor it and make sure that it doesn't get out of hand.
Okay.
Sorry, I don't have a.
No.
Not that I'm aware of.
Thank you. For flagell powder, why we need a contact layer first, then powder?
Because it tends to get in those cracks and crevices of the fungating tumor, and it sticks in there. It's hard to get out. You don't want to be scrubbing, and it just tends to build up and get messy. That's really all. I mean, you could do it.
Okay.
It's not really going to hurt the patient. It just gets really messy.
Okay. If for dry wound, can we use the flagell, IV flagell?
I don't think that's going to affect it as much because it's the necrotic tissue on the wound surface and the drainage that's causing the odor. Usually topicals work better. I don't have any research behind that though. Just what, I've learned in my practice.
Okay. So we use it 1 time a day or 2 times a day?
I guess it depends on how much odor you're trying to control. Like if you need 2 times a day, do 2 times a day. Like they could even open it up and sprinkle it on and cover it back up. But then when the odor is more under control, they could go decrease the frequency.
Thank you.
You're welcome.
Do you have any experience with Protect versus the Aquaphor? Protect.
No.
This is the best thing we have for our radiation burns. It's a similar product, but it's called Protect.
Can you spell it?
Prutect. And I've had one of my friends had radiation, and she called me. She goes, "You're my favorite wound nurse." And they're putting Silvadene on, and she said, "I can't sit, I can't lay, I can't walk." I got her Protect. She said within 2 days, she gave me a call, and she said that stuff's a miracle.
There you go. Everybody write it down. Prutect. Protect. Thank you. I'm going to be looking that up. Anybody else? Thank you so much. Thanks, guys.